Hi, I'm Carolyn Lund, and I'm going to talk to you today about skin science, evidence-based skin care for newborns and infant skin. So in this brief presentation, I want to review, first of all, some of the anatomic features of the skin that are different in newborn skin and premature infant skin. And then we're going to focus on some of the clinical care practices, specifically bathing and the care for diaper dermatitis. So the layers of the skin are displayed on this netter slide. And as you remember, the uppermost layer is called the epidermis. But there really are two components to the epidermis. There's the stratum corneum, which is the uppermost layer, and it is a non-living layer of tissue. It's comprised of fat and protein that are arranged sort of like the bricks and mortar of a wall. The importance of the stratum corneum should be stated in that the stratum corneum provides the barrier function of the skin. And as we're going to learn, there's real problems in the skin, particularly of premature infants, in terms of the development of the stratum corneum. Underneath that is the basal layer of the epidermis. That's where you have the keratinocyte cells that later migrate up to provide the keratin or the protein portion of the stratum corneum. Underneath that we have the dermis. The dermis is really what you appreciate when you look at your skin. This is also largely a non-living cellular mass. It's comprised of collagen and mucopolysaccharides. But there are some important structures that are in the dermis. There's the hair follicles, sweat glands, sebaceous glands. Nerve cells are also in the dermis. And underneath this we have the subcutaneous layer. It's fat, and it's largely deposited in the third trimester of pregnancy. So a premature baby, for example, who's born at 28 weeks probably doesn't have any or a very little subcutaneous layer. Now, when we talk about skin science, I think that this slide actually says a lot about it, in that it shows you some of the instrumentation that we use to measure skin parameters. Now, TEWL stands for transepidermal water loss. This is a measurement of how well the stratum corneum is functioning. It tells you how much water vapor is released through the skin, and it's measured against the gradient of water vapor in the climate. And we've used this in a number of studies where we look at how effective the stratum corneum is functioning. Now, next to that on the right is a measurement of the pH of the skin. This measures the acid-base balance, or the acidity and alkalinity of the skin surface. And then we also, on the left side, have a measurement called stratum corneum hydration. And this measures how well the stratum corneum holds on to water. Another device that we've used in some studies is called a colorimeter. And it actually is a measurement of erythema in the studies that we've done, but there are similar devices in clinical practice that actually can measure jaundice, and this is the transcutaneous bilirubin meter technology. So visual inspection scales are also used in research, as well as skin cultures. So the stratum corneum, these are photomicrographs showing the difference between adult stratum corneum, newborn, and a premature infant. The yellow arrows is pointing to the layers, which I think kind of look like phyllo pastry. There are 10 to 20 layers of stratum corneum in an adult skin. But similarly, there's a well-developed stratum corneum in the full-term newborn. And it kind of makes sense if you think about the fetus floating in amniotic fluid for months. If their skin did not have an efficient barrier, it would become extremely macerated. But the premature infant on this photomicrograph is about 28 weeks gestation, and they have about 2 or 3 layers of stratum corneum. You know, we see babies as small as 23 and 24 weeks survive, and they have virtually no barrier function of their skin. This, of course, is a huge problem in terms of releasing fluid and heat through their skin. They have a lot of insensible water losses through their skin. But in addition, you know, the skin barrier is also a protection against microorganisms and against topical agents that could cause toxicity. And if you don't have a well-developed barrier, you could get into problems in those areas. Now this photomicrograph, if you look very closely, you will see that there's little black arrows that are pointing to connecting points or fibrils between the epidermis and the dermis. Okay, so the top 2 layers of your skin are attached with these little proteinaceous fibrils. You can see there's a lot of little black arrows or connecting points in the full-term infant, and there are far fewer in this premature baby, again, of 28 weeks. So you can see there's a couple lined up, and then there will be big spaces where there's no connection between the top two layers of their skin. Well, one of the main clinical applications of this information has to do with adhesives and adhesive removal. And if you look at that baby's picture on the bottom, you'll see a little round circle that's red and shiny looking. And literally, we have stripped off the epidermis from this infant when we removed a piece of adhesive that was holding on a temperature probe. So this, of course, is a huge issue for us that work in NICUs. It also has implications for babies that have epidermolysis bullosa or a blistering disorder. Some types of EB have defects in these fibrils. Now, another variation has to do with the pH on the surface of the skin. At birth, babies are born with an alkaline pH. And it's generally measured at greater than 6 for the first 4 days, and then it falls to an acidic surface. This was work done, 30 years ago by Barrington Green. This acid skin surface, or what we've termed the acid mantle, is actually a really protective function for the skin. It is very inhospitable to pathogenic microorganisms like gram-negative bacteria and yeast. It obviously allows normal flora, such as Staph epi, to proliferate on the skin, and it will do that over the next several weeks after delivery. Now, premature infants also develop at least some degree of acidity. In a study from Fox in 1999, they measured the acid-base balance on the skin and found that a premature infant at a week of life measures about 5.5, and at the end of a month, it's about 5.1. So most would agree that this is some protection, some form of acidity. What they don't tell you when they did this study, though, is how they took care of the skin. Did they bathe the babies every day? What kind of products did they use? Did they use emollients? And then another variation in pH occurs in the diaper area. And it turns out that skin that's exposed to moisture and also to urine, it changes the pH on the surface, so that the skin becomes a little bit more alkaline, and this is actually part of the reason why that skin is prone to breakdown from diaper dermatitis. So the last developmental variation has to do with the increased toxicity that we see from topical agents in newborns. One other variation is the dermis is not as thick, and so the blood supply is probably a little bit closer to the surface. There's also, of course, a big discrepancy between how much their body weighs and their surface area of their skin. So a little bit applied to the skin has a lot more impact in terms of systemic circulation. In addition, premature infants have the underdeveloped stratum corneum, which of course is another way that we keep topical agents out, and so their skin is much more permeable. So I have a couple examples of these permeability problems. I call them misadventures in neonatal care. This one I thought was very interesting because it was from the 1880s. A physician, Dr. Rayner in London, noticed a problem among the normal newborns in their nursery, and these infants were presenting with cyanosis. And he found out and linked later the fact that they were sitting in a cloth diaper that had been stamped with the hospital's name. And the hospital's name was in this aniline dye, a blue dye. And the babies were absorbing the blue dye through their little bottoms, and it actually competed with oxygen for the hemoglobin binding, and they got methemoglobinemia. This is a very serious, almost life-threatening problem, and it occurred in full-term infants. So this, I think, has a certain degree of significance, if you will, for diaper dermatitis management and the products we choose. Now, this booklet is an evidence-based skincare guideline. It was actually supported by 2 nursing organizations that care for newborn infants, FAAN and NAN. And the process is that we developed a science team. I was the team leader, but there was a pediatric dermatologist as well. And we reviewed over 200 papers for inclusion. We wrote an evidence-based guideline. We made sure that every point had at least some support as best we could find it in the literature. And then we actually evaluated it in 51 nurseries across the United States. Of course, time passes on, and we had to sort of revisit the literature, reviewed another 150 papers, and reissued this guideline in 2007. So today we're actually going to look at bathing, vernix, diaper dermatitis in terms of the evidence base for these practices. So the guidelines suggest that, of course, we should not bathe a newborn infant immediately after birth. And yet in many hospitals, that was the practice. They would just dunk them under a faucet. Instead, we recommend waiting until the vital signs and temperature are stable, and at least an hour should go by. There is some evidence to support an hour is safe, but again, I think that's done more for the convenience of the health professionals and not for the baby and the mother, who would rather have that time just for bonding. Interestingly enough, although antiseptic cleansers are used in a lot of facilities, a lot of hospitals, they really have never been recommended by the Red Book of Pediatrics nor the CDC. So that became a practice of hospitals that didn't really have an evidence to support it. Of course, we recommend universal precautions for the health providers until the baby is bathed, and that it's not necessary to remove all of the vernix. Now, what is vernix caseosa? This baby is coated with this cheesy substance that's composed of sebum and broken off lanugo. There's some desquamated cells. And it's interesting because it's unique to the human mammal. There's no other mammal that produces a substance like vernix. It's primarily water. I was very fascinated to learn that because it doesn't have, a watery it doesn't feel watery to the touch, and yet it's primarily water with lipids and proteins. It starts to be produced in the fetus at the end of the second trimester. So babies that are born prematurely do not have the advantage of having vernix. And most babies, if they're heavily coated, are usually between 36 and 38 weeks. But another interesting fact about it is that as the vernix starts to detach from the fetus, the levels of pulmonary surfactant, as we know it's so important, start to rise. So there might be a connection between vernix and surfactant that we don't really understand at this time. Now, this is one of almost 20 papers that we reviewed in our last go-round of the neonatal skincare guideline. Vernix has become a hot topic for skin research. There isn't a lot of clinical relevance yet that we've been able to get from this research. And yet I think it's very interesting in this particular study, which they claim is the first systematic assessment of vernix in 50 years, they were able to determine that if you don't take all the vernix off, that it does contribute to a better hydration of the stratum corneum, more hydrated skin, and it also assists in the formation of that acid mantle on the skin surface. So it turns out to be very helpful to the fetus and to the newborn if it's left in place. They consider it a naturally occurring cream to facilitate adaptation to the extrauterine life. And some of the researchers, particularly in this group with Marty Vischer and Steve Hoth, are talking about developing a vernix type of product to use for premature infants, because we don't have a way now of really facilitating their adaptation as successfully as the full-term newborn has. So another area that's actually received a fair amount of research is the area of bathing and skin flora. In one of the studies by De Kahuna, they randomized premature infants to either get a soap and water bath or a water-only bath. And what they found was that there was no difference in colonization with bacteria between the two groups, and that both types of bathing led to a brief transient reduction in skin colonization, but that the bacteria quickly built up to where they were. Quinn in 2005 randomized premature babies to get, an every other day bath or every fourth day bath, and again found no difference in skin colonization. Medvez in 2001 took a group of full-term babies and randomized them to either a cleanser and water or water-only bath, found no difference in colonization, and just noted the fact that skin colonization increases over time, which you would expect. Now, I'm not opposed to bathing personally. I do it every day myself, but I do think for our newborns, it might be better to bathe them no more than every other day. So this is sort of a summary slide that studies indicate bathing with cleansers or water will briefly reduce colonization, but then colonization picks up again and it doesn't affect pathogenic bacteria. Now, an editorial in one of the pediatric journals asked this question about, should we reconsider antimicrobial bathing? And this is because, of course, the growing concern in the United States and other countries with MRSA. In fact, in one report from Texas Children's Hospital, they talked about the numbers of newborns that were arriving in their emergency department at 7, 14, 20 days of life with cellulitis, impetigo, and other, obviously, skin-related Staph aureus infections. And I believe over 30% were MRSA. So that's a serious concern. But again, we have to ask the question, would an initial bath with an antimicrobial really make a difference? You don't even have the skin colonization at that point. Where is the baby getting the MRSA? Maybe they're getting it at home. So it's a hard question to answer in terms of efficacy. But we also have to remember the misadventures of the past. And this is another one of these problems that we see with permeability. This is the hexachlorophene story. Now, hexachlorophene, and the brand name, of course, is Physohex, was commonly used in the 1950s and 60s to bathe infants. And this is because they were having outbreaks of Staph aureus infection while they were in the hospital. In these days, of course, the newborns were in the hospital for 7 days with their mother, and they had them in newborn nurseries with all their little cribs lined up touching each other, and no one washed their hands. So, it stands to reason that they would have these outbreaks. They would give an initial bath right after birth, and then every 2 days bathe them with Physohex. And then case reports started to flow in about infants who had died and on autopsy had brain damage that was a result of absorbing hexachlorophene through their skin. And that's why we stopped using hexachlorophene. It seemed to occur most often, of course, in the premature infant, or if a baby had a skin disease or some skin rash of some sort. But if you think about it, a bath is a pretty big exposure to a topical agent. And so I think we do have to be careful before we make any steps in terms of antimicrobial cleansing, although I'm sure that there are probably some hospitals and nurseries that are considering this. Now, when we talk about cleansing agents, we call everything soap, or at least I did, until I started to read and educate myself a little bit more. Soaps are actually pretty rare to find in today's world. Soaps are made from animal or vegetable fat and lye, and sometimes they add emollients. Examples of soaps are like Castile soap, and green soap used to be popular in hospitals and now not so much. What we are using on ourselves, and probably for the children that we care for, are cleansers or synthetic detergents. Another term for that is a syndet. And these also have a lot of variability in terms of the chemicals that are involved in them. For example, if you have a product with sodium lauryl sulfate, that's going to be a lot more irritating of a cleanser. In fact, in dermatologic research, they even use sodium lauryl sulfate to induce skin irritation. Whereas if you see a product with sodium lauryl sulfate, it's a lot more gentle. Obviously, we want to select products that have a neutral pH. And I also, on this slide, show some pictures of specially formulated cleansing agents that are really not cleansers at all, but contain emollients, what they call soap substitutes. Now, these are designed for patients with dermatologic diseases such as psoriasis and eczema. We don't really think there's evidence to support the necessity of using that grade of product in the newborn. So I think the main thing is just to bathe them less often. Now, this is one of the few studies that I found that looked at directly the effects of cleansing agents on the skin surface. And so this is a study involving 40 infants ranging from 2 weeks to 16 months of life. They were all hospitalized in a children's hospital in Vienna. They randomized them to either a water bath, a liquid cleanser and water bath, a bar or compact cleanser and water, or alkaline soap. And they measured the pH, the fat content, and the hydration of the stratum corneum. And what they found was interesting, and that was that there were elevations in pH and decreases in fat content and stratum corneum hydration in all of the groups. Of course, it reached the highest level of significance with the alkaline soap. And so each agent does influence the skin surface. This is the kind of research we'd actually like to see more of to help us in terms of really defining the best products and also the best regimes of care. So for now, the guideline says use a mild neutral pH cleanser, bathe every other day or less frequently, avoid rubbing, don't use a washcloth, use the mother's hands or the nurse's hands, and use rinsing techniques rather than rubbing, and consider immersion bathing. Premature infants, we're still recommending in the guideline to use warm water only for the first week. This was a decision that really wasn't based on a study because nobody has studied this effects on the skin. We know that it doesn't seem to make a difference in terms of colonization. However, in certain communities, it might not be such a benign thing to use their water, especially without a surfactant or something to make it a little less irritating. We call it hard water, but certainly if there are a lot of chemicals, there really might be issues with a water-only bath. So we're open and actually hoping to see some more research to help us. And I mentioned considering immersion or tub bathing, even for stable premature infants or babies before the umbilical cord detaches. And that's interesting, isn't it? And it's something that is supported in the literature. I'm going to show you one study. This was a study of 102 newborn babies. They were randomized to either get a sponge bath or a tub bath. And they found that the tub-bathed babies actually had better temperatures at the end of the bath and also seemed behaviorally more content, and that makes sense. It's less irritating and less exposure for them. No differences in cord healing scores, and mothers rated the tub bathing as more pleasurable as well. And there are other studies that we included in the guideline, but I just wanted to show you an example that it is safe to bathe these infants. Now, the last segment I'm going to talk about is diaper dermatitis. There are two main offenders, if you will, in terms of the diaper dermatitis in the infants. One is irritant contact diaper dermatitis, and that's the baby on the top. And you can see that there's a lot of perianal erosion. Sometimes it'll just be redness, but if it is allowed to persist without intervention, you'll get this picture. The other is a candida or fungal diaper dermatitis. The pattern is different. You see satellite lesions on the thighs, on the symphysis of this baby. And sometimes you get a combination. It's very, very rare to see a bacterial diaper dermatitis. So how do you get, what is the pathogenesis of the irritant diaper dermatitis? Well, there's actually three components. Wetness, which leads to maceration of the stratum corneum and impaired barrier function. There's friction, just the mechanical trauma of skin against cloth or skin against the synthetics of disposable diapers. And then, of course, the presence of urine and feces. There are urases or certain enzymes in stool that actually can cause the urine to release ammonia. So that's part of it. This ammonia causes an increase in skin pH, so it becomes more alkaline. You lose your acid mantle protection. In addition, this increase in pH activates other enzymes that are found in feces. So it activates lipases and proteases. And if you think about it, what is your stratum corneum made of? It's made of fat and protein. So it starts really to digest them, if you will, with the presence of the feces against the skin. Now, here are some of the risk factors for contact irritant diaper dermatitis. Malabsorption is a big problem, from short bowel syndrome, infectious diarrhea, opiate withdrawals, another example. Fecal incontinence, for the specialty babies that I take care of, we don't think of babies having continence, but literally they do. Their rectum holds onto stool and they defecate 3 or 4 times a day. For some babies, an example is the Hirschsprung's babies who have the pull-through procedure. They have a constant dribbling of stool, and it's constantly in contact with their perianal skin. Babies that have anogenital malformations, spina bifida is another example. Babies that have atopic dermatitis in infancy are certainly going to be more prone, and just the sheer fact that they wear diapers puts them at risk. So this is an example of a very sad case that I took care of. This was an infant that came to us with a full thickness wound from diaper dermatitis. And the underlying cause in this situation was opiate withdrawal. And so what this child, I mean, definitely we had to address the skin concerns, but it was a medical problem that needed to be treated, and whenever possible, treat the underlying cause. You have to, come up with a clinical diagnosis. Maybe there's a need to manipulate their diet, make them NPO for a while or whatever. But for the most common kind of contact irritant diaper dermatitis that you're going to run into in the community, I think this is probably the most important message. The treatment products that we use, the purpose of them is to create a barrier. And what you're doing is protecting the skin from the irritant of fecal enzymes. So the products don't need to have great healing properties or anything, because the skin will heal if it's not constantly being re-injured. So one example is the products that have zinc oxide. Desitin actually has twice the zinc of zinc oxide that comes in a generic form. Now, whether that's of benefit or not, I don't know, but from my clinical practice, it does seem to be a very sturdy barrier that will protect the skin from re-injury. Underneath that is a product that we use largely in hospitals, that it's a pectin paste that doesn't have alcohol in it, that really can hold up to some of the more eroding type of fecal material. There's also clear paste, and the product on the bottom is a rather newer product. It's called a plastic polymer, and it's actually FDA approved for babies greater than 30 days of life. So for fungal diaper dermatitis, obviously you need an antifungal ointment. We usually start with nystatin. Sometimes, though, we run into candida that's resistant to nystatin, and then we implement something called chlorotrimazole or another antifungal cream. This is a case study that I just wanted to tell you about, because I think in the pediatrician's office particularly, you're not going to see the real mild diaper dermatitis. You're going to see the really bad ones that come in with that diagnosis. This baby had a pull-through procedure, and the laparoscopic pull-through is now becoming maybe not entirely the standard, but commonplace. And when you combine this early pull-through with neonatal skin, it's really been quite a challenge to handle. So this baby has a lot of perianal erosion, also has a fungal component up on the thighs and so on. So one of the problems is if you put an ointment on, like the nystatin ointment, you are not able to get a barrier to attach and stick and protect. So you've got this problem, and what we've done in this case actually is use the nystatin powder, and we sort of brush on some of the powder and then seal it on with the plastic polymer and then put our skin barrier, either a zinc oxide paste or a pectin product in that case. And we were able to get this child to heal, but boy, it wasn't easy. So in summary, the primary irritant that is in contact diaper dermatitis is fecal enzymes. You need a protective coating, either zinc oxide or pectin or plastic polymer, to protect the skin from re-injury. And this concept really, if people can understand it, if parents can understand that, it's going to help. Also, treat candida with antifungals, and avoid products with multiple chemicals. Now, there are a lot of products out there. There's probably 40 different diaper dermatitis treatments. Many hospitals have their pharmacy compound products. And one nurse was telling me that their butt paste at their hospital always contains antifungal agents. And I thought, that's really not good, because you're treating a lot of kids with antifungals that don't need it, and you might not get the same barrier effect. So these are some of the chemicals we've seen in products. Peruvian balsam is another real popular one, and why they put it in, I've never really been able to understand scientifically. So what is the future of skin science for newborns? Well, I think I've shown you, and we've certainly learned in doing this guideline, that there is some scientific evidence to guide certain elements of skin care for newborns and infants. However, I believe more is needed. And one of the very intriguing questions is, does skin care in the neonatal period influence skin care conditions like atopic dermatitis because of early problems or alterations with the barrier? So there's actually some pediatric dermatologists that are pursuing this line of thinking, that in other words, you take a patient, a baby with a genetic predisposition to eczema, and you give early on insults to the barrier, and you could really maybe trigger off that disease. So one area of research we would like to pursue is to evaluate how various skincare regimes and products affect the barrier function of the skin, both in terms of bathing, emollients, and other practices as well. Well, thank you so much for your attention. I'll be here to answer any questions, and I hope this was somewhat interesting for you.